I see that it's 11:58. I'll give just a couple more minutes for make sure everybody has a chance to sign on, and then we'll begin. Before we begin, I see one question in the chat. It's the question is, will this be available afterwards? And I do believe we're trying to record this. And so yes, and so Erica has replied on the chat to everybody. So yes, we will be able to share this afterwards, and I assume we'll put it up on our website at a couple places. And we can send an email out to everybody who RSVP'd to let you know when it's up and where it's at. And it'll likely be available via YouTube, Facebook, and our website, the onehealth.tamu.edu. And we'll probably put it up on the Scowcroft sit-up website as well. Okay, I see that it's 12 o'clock, and I'm going to go ahead now and attempt to share my screen. Okay. Well, again, I want to thank everybody for joining us this afternoon on another chat, this time a lunchtime chat, and an update on COVID-19. And again, I want to remind everybody, I originally started this to continue sharing time and my own kind of lessons learned through my career, and share and to continue mentor some of the students that I had in a graduate school class this last spring. But we also made sure that it was more widely known. So I want to thank any of the students who are still participating, and I really want to welcome any faculty, staff, and members of our community who have joined us as well. So I hope this is useful to everybody. It's useful to me. It makes me keep up to date on things as I follow things pretty closely here. I also want to, in addition to an update, I want to share some policy observations and things that I've worked on over my career, but also as I look forward after this crisis is over. And so I've titled this Lessons Observed and Not Applied to Lessons Learned. And this is a part of this presentation I actually provided to the New York Academy of Science about 10 days ago at a pandemic summit, virtual pandemic summit. And I had the honor of also being on a panel with one of my former bosses who was the Assistant Secretary for Preparedness and Response at HHS, Dr. Nikki Laurie, who's now at the Coalition for Epidemic Preparedness Initiative. So with that introduction, I will go ahead and start. So again, I'm going to do a little bit of a summary of the COVID-19 timeline since December. It's been 6 months, almost to the date, since the WHO was notified from China that there was an unusual outbreak in Wuhan. I'm going to provide just kind of a quick situational awareness using data and analysis from data from the Johns Hopkins Data Repository and also the CDC. And this is where I'm going to kind of get into the policy, lessons observed, not applied to lessons learned. And a lot of that's kind of based on a lot of my career experience. I'm going to talk about the need for COVID-19 after action, and maybe some of my own kind of personal thoughts on that at the moment. And then what happens next as we continue to go through the COVID-19 crisis. So the COVID-19 crisis evolution in the last 6 months. Again, December 2019, unusual pneumonia cluster reported in Wuhan. 31 December, China notified the WHO. 23 January, Wuhan locked down, but the virus was already on the move. This was a very significant date. And I think as we do the after action and look back, I think this will be analogous. Those who are my age, who are listening in, I think vividly remember the days after the terrible 911 attacks on the United States. And you may remember that it was being reported, and we talked about it in the year or two afterwards, that there actually was a lot of chatter and a lot of intelligence chatter that should have warned us about the 911 attacks, and perhaps we could have prevented it had we paid attention to the chatter. Well, I think as we look back and do the after action, this date, 23 January, when Wuhan was locked down, was a major warning signal for the world. And we were slow to respond and see that signal and listen to that chatter. So that's just my personal thought. We'll see how the after action analysis is done in the next couple of years. So late February, crisis began to unfold in Italy. Late February, we also had the first reported death in the United States. Mid-March, the crisis was unfolding in New York City. And then we transitioned really as a country, the United States, from a case-by-case containment to broad community mitigation with shelter-in-place orders. So May, July, the economy, we began to kind of reopen slowly. So we were beginning to open our economy, or are we? And so the pandemic is far from over, but really what just happened? What just happened over these last 6 months? And so we're going to dig down into that a little bit. So here's just the current situational awareness. So as of 1 July, there's over 10 million cases in the world. And it seemed to be plateauing, through April, May, and then we have a very significant uptick around the world, beginning in May through June, through the current day. And we're seeing a lot of heavy burden, countries like Brazil, countries in Latin America, India. So this is not a good sign. Global deaths, although they were on the downswing, seem to be plateaued, but this 7-day moving average really tells us that the global deaths are also beginning to kind of uptick as well. And we have over 500,000 people have lost their life to COVID since this started. So the United States, kind of a similar type picture, over 2.7 million cases as of 1 July, and a definite uptick on a daily basis and our 7-day moving average, and we're over 2.7 million cases. The deaths in the United States have been on a downward trend, but have kind of plateaued. We don't know whether this is going to go back up about a month from now, but I would say that this is a snapshot really of where the virus has been. It's not a snapshot of where it is. So we're kind of looking at it, what has happened. And anything that's going to happen over the next 2, 3, 4 weeks is really already baked into what the virus is already doing and transmitting in our communities. So I hope that this does not, the deaths in the United States does not go back up, but we almost have to anticipate, sadly, that it may. So the burden closer to home in Texas, same picture. We're seeing a very significant increase in the number of cases really since the 10th of June until now. So just in 3 weeks, we're seeing a very significant uptick in cases, over 170,000, 75,000 cases, and now we're up to over 2,500 deaths. And I would say in Texas, this is a clear kind of slow uptick already in what we're seeing in fatalities, even in Texas. This is not a flat line anymore. It is starting to go up. And just, so what I should have talked about what these graphs mean. And so the blue lines, vertical lines are daily new cases. This green line is a 7-day moving average on those daily new cases. And then the red line here is the cumulative number. So we have cumulative numbers on this side, daily new cases on the left axis. And then it's just reversed. For red is the fatalities, and blue is the cumulative here for fatalities. So Texas, again, we have very large state, very heterogeneous, but our major burden is in the Dallas-Fort Worth area, the Houston area, the I-35 corridor. And just to plot that data out, the I-35 corridor, the daily new and confirmed cumulative cases, same picture. Since about 10 June, all the way up to now, we have a very significant increase in the number of cases. Same thing in Dallas-Fort Worth area. Perhaps it started earlier. mid-May or late May through now. In the greater Houston area, it's bigger than just Harris County and Houston. It's about 4 counties in the greater Houston area. Same picture, significant uptick. And then very close to home in Brazos County, we are seeing again a very significant uptick in the number of cases in our own hometown. Now, laboratory testing in Texas, we continue to increase our testing capacity, which is a good thing, a very good thing in Texas, increasing the daily capacity and daily number of tests. Unfortunately, the positive ratio to number of tests on a daily basis is actually going in a wrong direction. We'd like to see this positivity ratio into 3 to 5% range. We're up to about 15–16% range of the positive ratio of positives to total tests. So that really kind of is an indication that we do have significant community transmission of SARS-CoV-2 in our communities, and we're not doing enough testing, even though our testing is dramatically increased. Now, hospitalizations in Texas. Unfortunately, hospitalizations are also going up, starting almost the same date, that 10 June timeframe that we're seeing a significant uptick in the number of hospitalizations, over 7,000 hospitalizations. Now, the good news here is we seem to have significant, sufficient capacity in our hospitals as far as staff beds, available hospital beds, available ICU beds, and available ventilators. So on the one hand, that looks okay for our hospital capacity, and that was really one of the goals of flattening the curve, if you remember, is to make sure that we had hospital capacity to be able to appropriately and care for those who got most sick. Unfortunately, though, if we look at the regional basis in some communities, we are starting to see some of the hospital capacity and ICU capacity is already starting to strain. And I'm also hearing that we might be even having difficulty in the staffing. So this is something we're really going to have to pay attention to, is our hospital staffing and ICU capacities as we move forward. So I want to also then kind of a situational awareness. This is from the CDC Morbidity Mortality Weekly that was just published June 19th, but it's probably one of the more comprehensive disease surveillance analysis to date on the burden of COVID-19 in the United States, that looks at the incidence of age, and in age with the comorbidities or without comorbidities. So the bottom line, this was a cohort of that included 1,324,488. We had good data on a subset of this cohort on hospitalizations and also the kind of morbidities that were associated with the people the patients that were hospitalized. But the bottom line summary of this kind of cohort of over 1.3 million people, of lab confirmed cases, these were lab confirmed cases, there was a 14% hospitalization rate. If you did not have any underlying health conditions, it dropped down to 8% hospitalization rate. But with underlying health conditions such as cardiovascular, endocrine, obesity, and so forth, that shot up to a 45% hospitalization rate. And in ICU, it was a 2.3 overall total, 2.3% hospitalized. It was lower if you didn't have any underlying health conditions, but it was higher, up to 8.5% with comorbidities. And in death, again, I don't mean to minimize when I mention death as a statistic, because there's a sad, very, very sad story about every family member who lost somebody to COVID. But out of this cohort of lab confirmed infections, 5.4% died. And I have this backwards. If you had a comorbidity, it was actually, this is I have these in the wrong boxes here, but if you had a comorbidity, that actually went up to almost 20% chance of dying with a comorbidity. but it dropped to 1.6% if you had no underlying health conditions. But it's also interesting to look at that by age. This didn't account for the age, but if you look at it by age, we see a significant, much higher percentage of hospitalization rates if you're over 80 or in the 70 to 79 age demographic or the 60 to 69 age demographic. There's no doubt the older age demographic is also associated with a higher hospitalization. But guess what? The younger demographics also are hospitalized as well. I think there's a misconception that if you're young, there is no severe disease. It's only hitting the older demographics. I think that's a misconception. And so we do see hospitalizations, and some of those could have longer term effects. And the hospitalizations of the younger demographics that have comorbidities is not insignificant. And then further, just, it's a very similar story, the age demographics and the ratio of age with ICU admissions and as well as deaths. But I want to also point out, even though the higher fatality rate in the older age demographics, the younger age demographics, there are deaths in the younger age demographics as well, although the percentages are a lot lower, thank goodness. And most of them, particularly under in the 40 and younger, are associated with underlying health conditions. But nonetheless, again, it's a myth. If you're young, you're not going to suffer severe illness. You may end up losing your life. So now I'm going to switch gears again, and we're going to talk about COVID-19, the pandemic, where we've been, where are we going, and then I'm going to insert some policy lessons observed as we talk about this going forward. And so again, to summarize, I've mentioned this and discussed this before, the 5 phases of what I call the 5 phases of the COVID-19 pandemic. We are in phase 3, but again, the 5 phases include containment. And then number 2, we went into phase number 2 in about mid-March, implementing broad community mitigation measures and interventions with shelter-in-place orders. Since about May 1st here in Texas, we moved into phase 3. This is what I call phase 3, and it's containment with targeted community mitigation interventions and before a vaccine is available. And there's also going to be a phase even after we have a vaccine available. Vaccine is not going to solve all of our problems. Will it be helpful? You bet it will be helpful. And then 5 is preparedness, so we can prevent this from happening again. Now, a little bit of summary. Emerging infectious diseases with pandemic potential actually is not a new phenomena. And in fact, over the last 15 years, we've had just a ever-increasing number of outbreaks that have been pretty serious and significant, and have had cost us quite a bit in disease and morbidity, as well as financial cost and response. And many of you will recognize these diseases, and some of them are still with us, but the influenza viruses continue to circulate. In fact, there's a new influenza virus that has been just reported this week that has pandemic potential in China, a new H1N1 influenza virus that also is a little bit worrisome and has all the makings of a pandemic potential new virus influenza strain with SARS, West Nile, chikungunya, dengue, cholera, Middle Eastern respiratory syndrome, Ebola, and Zika. And so this is, I call it the ever increasing drumbeat of emerging infectious disease outbreaks, with some of them pandemic potential. Not all these do have pandemic potential. But Peter Sands was an economist who led a National Academy studies that was published in 2016. And they looked at, this is really a pivotal National Academy studies, another wake-up call, but I'm not sure we heard the alarm bell, but essentially called for an investment of about $5 billion a year to focus more on prevention of outbreaks. And if we don't do that, we don't make this kind of investment in the United States, we're going to be spending up to $60 billion a year on outbreaks. I guess we're way beyond $60 billion for this current pandemic that we're in, way beyond that. So a little investment in prevention might really, really pay off. We're gonna have to think about that for the future so this doesn't happen again. So I'm gonna go into now what I call after action findings. And I'm gonna use 4 examples of after action findings that actually I've been involved in either during the response in some way, maybe just being a scientist, but also in other ways being, in the Health and Human Services Operations Center and helping to coordinate all the federal public health and medical support in response to supporting state and local authorities. So anthrax letter attacks, as you remember, that occurred right after 9/11. In fact, the first letter was mailed exactly 1 week, was postmarked exactly 1 week after the 9/11 attacks. SARS in 2002, 2003, this was supposed to be our wake-up call, that we had to be better prepared for emerging infectious diseases with pandemic potential. The H1N1 pandemic of 2009 and then the Ebola epidemic of 2014, 2016. And so these after action, there's been numerous after action reports, studies, part of our work at the Scowcroft Institute of International Affairs, and I'm also supporting and work with the Bipartisan Commission for Biodefense, looked at these after action and did some analysis and make some conclusions with that. And I want to share some of that with you in a very summarized way. So the summary of all those after action reports, which were many, we identified numerous kind of what I call technical areas that seem to be repeated, things that are always observed after there's a crisis, an emerging infectious disease outbreak or some type of crisis. I'm just going to kind of read through that. You can look at these. I'm going to read through some of these repeated findings or repeated observations, repeated technical challenges. Actually, no, I call them repeated failures because we haven't made a commitment to try to fix them. And I think some of these will sound familiar as we're thinking about what we're going through right now with the COVID-19. Vaccines, not available. Nor is there, are we relying on decades old technology like flu vaccine. There's limited surge manufacturing, limited capacity for domestic and international deployment. It's not enough just to be able to do the research, manufacture. You got to also have to think about deployment. Therapeutics, very similar story. Access to scarce medical countermeasures for low middle income countries. We've got to make sure this is a global problem. We can't just solve the problem in the United States. We have to think about how we also support low middle income countries as well. Diagnostics surge laboratory capacity. We've had a little challenge in diagnostics testing, haven't we? Disease surveillance, real-time situational awareness, transparency, reporting, information sharing, sufficient research capability and capacity, including the ability to have multinational scientific collaboration in real time. International health regulation compliance. We haven't talked about much on that. This is going to be a major after action issue in the international health regulation compliance for COVID. Public health, medical capacity surge. I just talked about hospital capacities here in Texas. Public health and protection of healthcare workers and supply chains. I didn't mention how many healthcare workers have lost their life just in the COVID-19, but we've had healthcare workers die and other critical infrastructure personnel die of COVID because we didn't have sufficient personal protective equipment for them. Community mitigation, infection control procedures, handling of hazardous materials and decontamination, international response framework. How do we respond? Risk communication, and finally just communication. We've got to earn the public's trust. I'm not sure we're doing a great job with that right now. So it's almost like, have we learned anything? Well, I don't mean to paint a terrible picture. I do want to paint a picture that we have things that we need to, that have been long-standing lessons observed that we need to fix. So we have learned things and we have gotten better and we are much better prepared than we have ever been. But I think COVID-19 tells us we weren't prepared. So just a few things that, we have made progress, but there's a lot more to do. And I would say one of the more consequential, at least what Congress administration did back in 2006 was pass the Pandemic and All Hazards Preparedness Act. That created and provided new authorities, new organizations, and it was reauthorized in 2013 and 2019. But I think it's kind of clear that we're going to need to go back and take a look at this authorizing legislation and make some major changes in the PAPA Act. After Ebola, 2014, 2016, I think we began to really make some good progress. And one of the things that I think I take a lot of pride, pleasure in being a part of when I was still in government, was working on the policy for the global health security agenda. And that, I think, has made quite a bit of progress in a very short time in helping us build international institutional public health and animal health capacities in low middle income countries. It's going to take a lot of sustainment, a lot more work. And actually we began, through the global health security agenda, actually began to make progress in One Health. How do we apply One Health in the fight against emerging infectious diseases? We've actually improved quite a bit on our ability to surge our research enterprise to include doing multinational clinical trials that are very kind of essential for vaccine development. In fact, the Ebola vaccine that was just licensed about a year ago was used in the fight against Ebola in the Democratic Republic of Congo. But if that would not have been possible had that work not started in 2014, 2016 Ebola outbreak. And the Coalition for Preparedness Innovation, CIPI, was established after the Ebola outbreak. And I think it's one of the most promising public-private partnerships that's brought together philanthropic funding plus government funding. The United States did not contribute to CIPI, but it's one of the most promising public-private partnerships to develop vaccines against emerging infectious diseases, some with pandemic potential. The World Bank has looked at establishing financing to put more emphasis on prevention. And the WHO did establish the Health Emergencies Program after the 2014-2016 Ebola outbreak as part of their review and analysis and sharp criticism after that. So this is really kind of where the both the Scowcroft Institute of International Affairs and the Bipartisan Commission took a look at all these kind of repeated findings, technical findings over the anthrax letter attacks, the 2009 pandemic, the SARS in 2002, and the Ebola outbreak of 2014, 2016. And there's a number of technical type things, but really we kind of came down to the conclusion that the technical things cannot be fixed unless we fix some overarching problems that are also kind of continue. And really it's very fundamental things that are needed to be able to fix the technical things. And it comes down to leadership as one of the most important aspects of this. And I'm not talking about individual leaders. I'm talking about the need to have better organizational structures and a better organizational framework that will enable effective leadership. And I say that because just in the United States, our public health, medical preparedness, and emergency management preparedness structure at the national level, there's at least 12 government agencies that have a role in pandemic preparedness or biodefense at the federal level. There's at least 50 Senate-confirmed, presidential appointed, Senate-confirmed authorities that have some kind of responsibility for biodefense, emerging infectious diseases with pandemic potential. So you kind of get the picture that we have a large bureaucratic structure spread across many different agencies at the federal level. So it's extremely difficult to effectively lead, make hard choices, make the priorities, and make sure that the available funding is used in the most effective way. So it's that leadership is absolutely essential, that we improve our structure that can enable effective individual leadership. And then it's coordination, the ability to do more coordination, collaboration, communication, and really apply innovative technologies as solutions. And then also One Health is more recently in the last 5 years has become an essential part of our pandemic preparedness enterprise, not just because many of these infectious diseases jump from animals to humans. That's one reason. But One Health is really essentially, at the end of the day, it's about how do we work in teams, how do we work in multidisciplines, how do we bring the right expertise to bear on hard problems. And so we're beginning to make progress as well in applying the principles and the spirit of One Health in the fight of infectious diseases. So leadership, coordination, collaboration, communication, innovation, and applying One Health. These are kind of been overarching preparedness response lessons observed that we really need to apply if we're going to fix some of our problems and be better prepared in the future. Going yet, but there is a lot of finger pointing already. And it's unfortunate in our politicized environment that we're in that in fact, I'm really worried that that's going to mitigate our ability to really be thoughtful and objective and come out with something that's going to be useful and really help us fix the problem. And it's going to be hard to do right now, and I'm not sure the answer, but I'm going to stay in my science policy lane, and I'll let others worry about that. But no doubt, after the crisis subsides, this is not the time. In fact, this is not the time to do an after action. We are still deep in the crisis. Now's the time that we have to figure out how to come together and solve the crisis we're in. But nonetheless, once the crisis does subside, there will be many after actions will be conducted domestically in the United States and internationally. And again, I'm worried that some of the after actions will be more motivated by partisan views, and if they are, they're going to be counterproductive. And it's important, though, that divergent opinions, and divergent opinions are emerging, and that's good. We need the divergent opinions about what happened, what worked well, what did not work well, and what must be fixed. You know, there's no doubt scholars will be studying the COVID-19 for years. I know I'm going to be studying the COVID-19 for years, but we don't have years. We need urgent answers, like even right now as we're thinking about getting through this crisis. And we need urgent answers as we think about preparedness, even in the short to the midterm. And so about what our future directions are going to be now. And so we do have to look back, but we need to make sure when we look back, we're not looking back just at the last 6 months or even the last 30 days. And we need to be looking back actually at least a decade, because that really what happened over the last decade or what did not happen. So what did not happen over the last decade really kind of set us up for where we're at today. So as we do the after actions, we need to look back, not just when COVID started in December 31st, but at least a decade. But critically look what happened in the last 6 months as well. Unpack that thoroughly. Well, then it's most important, how do we have an objective and thoughtful analysis for the way forward? And so there is discussion now at several levels about how do we do that. And one of the models that's being discussed is, and those again who are my age, remember after 9/11, there was a nonpartisan, bipartisan 9/11 commission, that's what it's commonly called, but look back at the events of 9/11 plus what led up to the events of 9/11 and charted our path for as a way forward. And we never suffered another attack similar to 9/11 in our country since then. But it was a bipartisan commission. It was extremely thoughtful. It was extremely objective, and provided a path forward as we began our preparedness against future terrorist attacks. And so we need something like that on that scale, that order, very analogous to the 9/11 Commission as we think about what's needed for the COVID pandemic commission looking forward. And so, I think that's going to happen. I don't know when, but I think there's a number of groups that are already thinking about it. I talk about it when I get the opportunity, and I wanted to share that with you, that what I'm thinking. But I'll just share some of my own initial thoughts right now with the COVID-19 lessons learned. And again, these are just my thoughts. So these are very obvious conclusions. The United States was not prepared, but the world was not prepared as well. There is some good news, but I think this is where I think there's a lesson observed that was effectively applied as a lesson learned. And that's our scientific enterprise. Our scientific enterprise was mobilized in an unprecedented manner. Now there's some issues, some of the data is coming out so quick and maybe not peer reviewed and so forth. But nonetheless, it's just been to me, it's been one of the lessons observed there's become a true lesson learned. And our ability to surge our scientific enterprise has been just spectacular. But there are some past lessons observed that have not been applied, and they continue to be lessons not learned. And again, just to keep it at the high level, they fall in the buckets of leadership, coordination, collaboration, communication, and innovation. I don't think anybody will probably disagree with that. So what do we need to do now? And so we need to keep focused on getting us through this crisis. And I think these are really kind of the primary objectives. And I've talked about this before, just giving a little bit more detail on the slide than I have in the past. So we know more about the SARS-CoV-2 virus than we did 30 days ago. But I almost daily, I'm humbled. I am just humbled by how much I do not know, and how much, even though the scientific enterprise is mobilized in an unprecedented way, I think we're all humbled by how much we still have to learn about this virus. So we have to protect at-risk vulnerable populations. We need to strengthen our healthcare, public health capacities to test, trace, and triage. Now, I'm worried about this. I think this ability to test, trace, and triage at the community levels is extremely important to box the virus in. But with the rapid rate of new cases that we're seeing in the United States and some of the states that are being hit the most hard right now, Texas including, we're at the point where we're about to overwhelm our ability to do contact tracing because we have that many cases now. So we need to identify areas of virus spread, population immunity, and et cetera. We're going to need to continue implementing community mitigation interventions. Governor Abbott just did that yesterday with requiring face coverings across the state and also closing the bars in Texas. That's an example of a targeted community mitigation intervention. And we're going to need to continue to take a look at that, but it's got to be calibrated to the need at local levels to mitigate viral transmission. One size won't fit all in Texas for most community interventions, but we're going to have to look very closely what may need to be done in individual communities where we have a surge in cases. Continue developing our therapeutic post-exposure treatment, preventive treatments, and so forth, and provide critical care, maintain hospital surge capacity, secure essential medical supplies. Although PPE seems to be more abundant, I keep hearing information that PPE and N95 respirators is still a commodity that's not where it should be. Our vaccine development programs are being implemented, but in addition to vaccine development, we have to make sure that we have put in the logistics train for how we're going to distribute the vaccines once they're available. We have to make sure that we have the vaccine tracking, because some of the vaccines may require more than one dose. So we need to have vaccine tracking and post-marketing surveillance systems ready to also analyze, make sure that we can uncover if there's any untoward side effects, that we are surveilling for those. And then most importantly, we've got to figure out how to provide access to low-income countries. It's not enough just to immunize the population in the United States. We're going to have to work with our international partners to make sure that we can provide global access. And even in the United States, we're going to have to determine who gets priority in the first doses of that vaccine. And then finally, I think we have to do a much better job of communicating the importance of individual responsibility and infection control and community mitigation, whether that be, keeping your space, covering your face, hand washing, stay home and sick, and so forth. It seems like we're talking about this all the time, but it doesn't seem like either we're not doing a good enough job communicating this, people are not listening. It's probably a combination of both. But I think, I know I look at it as it's my responsibility to figure out and help how can we do a better job of communicating. So pandemic preparedness, my vision, where we need to be, and I think we would all share this vision that pandemic preparedness, it must become a national security priority. We need to resource it as such and provide, focused attention to it, so that we can reduce our risks and vulnerabilities. And I see this, where we need to be is domestic preparedness is a sustained priority. It's just not something we pay attention to when there's a crisis and we forget about it afterwards. That's been the history. There's a crisis, we throw a little money at it, we respond, and then we get complacent to the next crisis. So this has got to be a sustained priority. Global health security, international development has got to be a sustained priority that transcends different administrations. And we need to put more emphasis on preventing outbreaks in addition to having our ability to prepare for an outbreak, and apply One Health multidisciplinary collaboration to solve these problems. But this is going to require a lot more public policy advocacy. There's a reason why our politicians maybe had not paid attention to it, because their constituencies don't pay attention to it. So public advocacy is going to be important here. Political and resource commitments are going to be important here. So we've done this before. I mean, it's not impossible to do this. In the GW Bush administration from 06 to 09, we had a pandemic influenza national strategy and implementation plan, and even the first community mitigation strategy. But we need to go back and have similar type commitments that we did for about 3 years from 06 to 09. We have a model that can be applied today. It's going to require a lot more resources than we thought back then, and it's going to need to be sustained and have more international focus on it as well. But we have done this before, and we can do it again. So, and then finally, I want to just call your attention again to a book that was edited by Dr. Blackburn of the Scowcroft Institute, Preparing for Pandemics in the Modern World. And I want to call your attention that there's a panel discussion next week on July 8th. We can make sure everybody has how you can register for it before. The authors of this book will be on this panel discussion. I believe the title of the panel discussion is Learning to Live with COVID-19, or Learning to Live with SARS-CoV-2 virus. And I clearly fall in the camp that we need to figure out how we live with SARS-CoV-2 virus. We cannot continue to be sheltered in place. We've got to find the right calibration of maintaining, opening up our economy while living as safe as we possibly can with the SARS-CoV-2 virus. I'm just not afraid. I don't think we've figured that out yet, but we've got to figure out how we can safely live with the SARS-CoV-2 virus until we have a vaccine, and even after we have a vaccine. And then finally, the book is available for free download from the Texas A&M University Press. And I think that that is it. I will stop my screen share and we can go to some questions. And Erica, it might be easier, if you don't mind, if you would maybe be the moderator and read the questions. Can I ask you to do that? Do you mind?
Sure. Do you want me to read the ones that were submitted ahead of time?
Sure.
Okay. So the first question that was submitted ahead of time, at what case positivity rate would you say that we would have to lock down again?
Yeah, and I want to first say these were really some good, tough, hard questions that everybody sent in ahead of time. So thank you for sending the questions in, and some of these I have answers for, and some of them I don't. So the positivity rate, well, first, let me just kind of address my opinion. Maybe I already just said it in my kind of concluding remarks about closing down again. I hope that we can avoid having to close down again. Now, I guess we've already closed down a portion with the bars having to close down, and I heard yesterday too that the beaches in Galveston will be closed over the 4th and so forth. But it's not just one metric that we have to pay attention to. We are definitely moving in the wrong direction with the positive ratio of total tests that's above 15% now. That's definitely the wrong direction. I don't know what that number may be, but it's going to have to be calibrated. That ratio will have to be calibrated. It'll have to be calibrated against what is the hospital bed availability, what is ICU bed availability, and what is our hospital staff availability, what is the availability of PPE. So I don't think there's any one metric that's going to be the tipping point for saying that we got to close all non-essential businesses. And again, I hope we need to do everything possible to have to go back into that shelter in place. And why do I say that? Because once we begin to really put the brakes on our economy, that has all kinds of other unintended consequences to, if I just stay in my own lane in medical and public health, and mental health. It has all kinds of negative consequences, not to mention all the other economic consequences. And so I just hope we can avoid that. But we're going to have to watch all those metrics that I talk about, kind of the hospital PPE availability, hospital availability, and watch this metric of our positivity ratio. And I also, here's another question in the chat. Let me just, it's kind of related. It's about the importance of testing, who should get tested, and so forth. My best advice is always follow the advice of your healthcare provider. If you're not feeling well, you need to have a chat with your healthcare provider. That is always the best advice to do, is always follow that advice. But there's going to be, there are testing sites that are established, and I think there's going to be one next week in Brazos County. And if you feel like you need tested, go get tested. But I think it's always best to consult with your healthcare provider before you, in any event, have that conversation. Ask those, it's even whether you're, show symptoms or no symptoms. Because remember, if you're worried that you might have a close contact and you're not even aware of it, it's 40 to 50% of the cases right now may be asymptomatic. We're not quite sure, but there's a high percentage of asymptomatic or pre-symptomatic people. Next question.
Yeah, sure. So in the submission of these questions, there was a particular graphic shared, and I can share the link to that in the chat box, but it's a graphic from NPR. And the question was, given that we're seeing increases in many cases, surges in other states that didn't reopen early, would you say that we're now seeing infections from the protests, specifically in Ohio, Delaware, Nevada, Michigan, Kansas, Maine, Alaska, and Hawaii?
I don't think we have any hard data to tell us exactly why we're seeing cases, crop up now in the last month. Whether it's from the protests, whether it's from reopening businesses, I don't think there's any conclusive studies that I've seen. I'm not aware of. There may be some studies, whether they're conclusive or not, I don't know. Probably a lot of conjecture. So I think it's too early to say why we're seeing the rapid uptick, but there's no doubt. I think, if I just look in our own community, I don't believe that people have been paying attention to their own individual responsibilities when they're out and about in the community. I haven't, particularly kind of early on, I don't get out much. I stay pretty well hunkered down in what I call my command bunker here now. But I didn't see a lot of people really complying with keeping their space between other people. I haven't seen a lot of face mask coverings over the last month. And so I think it really is kind of the simple, however it may have happened, it's individuals are not complying with public health guidance for social distancing, face coverings. I can't comment about, I don't know about individuals' personal habits of washing their hands or staying home sick, but what I have observed just personally is that's maintaining space and covering their face.
So then,
what I have read, though, something last night that caught my attention, and maybe why bars, perhaps, why they maybe that they are particularly a high risk, maybe environment, because people really are very, very close together. Often the tables, whatever, drinks are spilled, so they're kind of sticky, can be pretty ripe for perhaps growth of microbes. So anyway, that I guess there probably is more discussion and perhaps some data of why they're particularly of high risk environments where people are really crowded together in an inside environment. Next question.
it's very much related. The next question was specifically about other states that reopened perhaps quote, too early, like us, Florida and California, but why has California been seemingly worse than us from a case and death point of view? And is there another reason besides people being less disciplined at mask wearing or social distancing?
I'm afraid we just do not know the answers yet. I'm going to be really interested in watching also what happens in some of the Northeast states that were particularly hard hit, like New York, New Jersey, actually even Louisiana, that was really particularly hard hit early on, because their case, whether they see a resurgence of cases, I think is going to be kind of interesting. Is that may also give an indication about the reopening of the economy. How did that play? So I think we don't know enough yet about why. But I think we know that the few tools we have in the toolkit to try to mitigate community transmission, not cut it off to zero, but try to mitigate, or what we can do as individuals. Unless we want to, shelter in place and close all essential businesses, which we know that has too many other unintended consequences.
I think that answers the third question there about other states seeming to have higher fatality rates than us.
It is, well, there's no doubt, I think, again, here's just a philosophy to think about too. You could also say that maybe Texas closed down too early. New York closed down when they did, and it was already kind of like out of control. And but when we closed down in Texas, another way to think about it, I'm just offering another way to think about it. We were not on an upward uptick in cases. And a pandemic, by definition, is going to hit different parts of the country, different parts of the world at different times with different intensity. So maybe we closed down too early. I don't know. But maybe we reopened too early. But I think the analysis is still in front of us to really understand some of these things. But I think as we see some of the other states in the United States that were hit so hard very early on, I think that may be informative too as they reopen their economies, and they really have just started doing that. But it's just hard to know. It's just, we don't know yet.
And then a very related question to what you just said, would you say that the early models going all the way back to February, which predicted the number of cases and deaths, have been accurate? And then do you think that since we went into soft lockdowns, the model had to change a bit because of that?
Well, modeling has received infectious disease and kind of pandemic and community mitigation modeling has received a lot of criticism over the last several months. And, I think it's important to note that actually this kind of science of infectious disease modeling is really not that old of a science too. Maybe of the degree that we're doing, and also modeling the community mitigation measures. So there's some degree of, whether they're accurate or not, but I think the important thing to me is the different models all pointed to the same direction. The quantity that they pointed to may have varied, but they all pointed in the same direction. And if we do nothing, we were going to have a very significant increase in cases and a very significant increase in deaths. And by doing something, the models told us that we could mitigate the number of cases and the number of deaths by taking certain community mitigation measures. Now that doesn't get to a quantifiable number, but I think from a subjective analysis, the models were accurate from that perspective. And then if you throw out all the models, but just take a very, very kind of simple analysis. We have 300 million people living, I guess it's 330 million people in the United States, but just take a simple number, 300 million. If we assume over the next 12 months, 18 months, half of the population is going to become infected, That's 150 million. Okay, what if 14% of that population is hospitalized? What if 5% or even 1% of that population dies? Do the math. That math is not too far off from those models. Now, I'll let y'all do the math.
We're all getting our calculators out. So a little diversion from what we've been talking about. Another question that was just submitted with, or that was submitted ahead of time, was we've seen one major agricultural domestic intersection in the animal and meat processing plants, the infections there. Given the average ages of domestic agriculture producers and the increased severity among older adults, what sorts of international agricultural footprint do you expect to see from COVID-19, and does it seem likely to impact supply chains?
No, it's that. I think I'm kind of surprised we haven't had more of an impact on our food security. I think that we, at least in the United States, we have been able to take some measures to mitigate the impact on our food access in the United States. I think as this continues, that we could see be it for more problems with just our food security and food availability, not only in the United States, but kind of across the world. Food is a critical infrastructure. And I think that was one thing that perhaps we were maybe slow on the response of recognizing the need to protect that vulnerable population who work in our critical kind of infrastructure, in that case, in our food processing plants and just food and ag sector. And I think we're kind of slow off the response in general across the United States, probably in the world too, just what critical infrastructure means and what constitutes that critical infrastructure, whether it be food, whether it be energy, whether it be healthcare, and those are the top three, I think, and making sure that we did the things that we need to do to protect those critical workers. But at the end of the day, we didn't have the PPE to do it. So whether, in all three of those sectors. And so that our real vulnerability was our supply chains. And that's happened over the last 10, 15, maybe 20 years, that we lost the ability to really control our supply chains. And it didn't become apparent until we had a crisis. We absolutely need it. And we couldn't protect our healthcare providers adequately. And we couldn't protect those that work in our critical infrastructure, whether that be in the food processing plants, other areas in ag, or whether that be probably in energy too. We haven't even talked about energy. And it also, I think, also highlights, some of our ag and food security. It highlights an example of why certain parts of our population also were more vulnerable. The socioeconomic and Hispanic populations, particularly, were maybe more hard hit because they were the ones that couldn't stay home. We needed them, to be in our critical infrastructure, and so we've got to address that problem head on to protect all vulnerable populations. So
we've got 3 more questions and 3 more minutes. So this is rapid fire style.
Lightning Q&A.
Yeah, so the first is there's much public unrest in terms of misreporting of the number of positive cases by testing centers. I think a lot of the unrest stems from miscommunication. How do we assert true information in the face of this distrust?
Yeah, that's a tough question, and we've gotten into this place where I don't think we have earned the public's trust. Whether it was a conscious misreporting or just it was, and most of the time I think it's more wasn't a conscious, deliberate misreporting. I think it's just also the evolution of how best to collect the data and how best to visualize the data. And that kind of gets into one of the repeated failures that I mentioned and all the other kind of things. Real-time situational awareness has always been a challenge, and real-time data and collecting data has always been a challenge. And I would say we've probably done a better job than ever in trying to collect data in near real time as possible, with all the shortcomings of testing and analysis, and how do we categorize a COVID death or a death that occurred in a patient that was positive for COVID? What does that mean? What are the different reporting criteria, not only across the United States and each state, but across the world? Because there are differences in how what will go on a death certificate in different countries. So we need some better standards when we think about the future. But the bottom line is and it's happened in past crises, we have not done a good enough job in earning the public's trust. And you can definitely see that at the national level.
Okay, last two questions, and they're pretty straightforward. So one is, what are the underlying conditions? We hear a lot about age, but what about heart disease, obesity, anything else? And then the last one is about whether cloth face masks are indeed helpful in preventing the spread.
Yeah, the comorbidities, there's a pretty long list. CDC actually, if you just Google CDC comorbidities or case surveillance, they have a lot of good information, but they kind of broadly fall into cardiovascular. That's a lot of things that fall under cardiovascular, hypertension being one of those, and endocrine. Diabetes is primary under the endocrine, obesity. So there's a number of them, and CDC has just updated some of those. So I would point you to the CDC website to get more in depth, but I would just broadly say cardiovascular, endocrine, obesity, and there's many things that fall under those three major comorbidities. And then I forgot, I having a senior moment. What was the
cloth masks?
Oh, cloth mask. Yes. And so, boy, the mask is just, and again, at the national level, has been confusing at best. The guidance over the last several months on mask, but I think the predominance of data now suggests that cloth masks, double layered cloth masks, are going to help mitigate disease transmission in the community. And there's actually even a little bit of information and data coming in, because I've spoken about this before, primarily to protect, in case you're pre-symptomatic or asymptomatic, it'll prevent you from spreading it to others if you did not know that you in fact were infected already. But there's some evidence now going that a cloth mask may also provide protection to the wearer, in addition to mitigating transmission to others. And so it is one of our only tools right now. And there's, I think there's, at least correlations of other countries that wear face masks, and their level of disease and burden and so forth is lower. So I just strongly recommend that it being one of the only tools that we have in our toolkit, that we need to pay attention to our local public health, state public health, and CDC now guide us that we need to be wearing face coverings and the cloth mask to protect others, and perhaps even provide a level of protection for you.
That's all we've got.
So if I have any parting thoughts, please everybody be an ambassador, and people you associate with and talk to, that it's very, very important. It's essential that we do wear face coverings, and when we're out and about in the community, that we maintain our space amongst others, wash hands often, and stay home if sick. Bottom line, avoid getting sick and avoid making others sick. We all have a responsibility here, and to help mitigate transmission in our community. So I'll stop there. And so again, I want to thank everybody for joining us. I hope my little walk through policy and a little bit sharing some of my experience in my career and what I think about what's needed now in the future was helpful and of interest. So thank you very much for joining us.